That's it. Okay. Right, we're recording now. So just get this into work. Hello, everybody. We're going to now talk a little bit more about bones with malignant disease. So we discussed earlier on benign bone disease. Now we're going to discuss the role of nuclear medicine in more malignant bone disease. So I'm going to talk a little bit about primary bone tumors and then bone metastasis, and a little bit at the end about FDG PET particularly, and how it works in bone mets. So primary bone cancers, we don't really have a role in diagnosis, and it's really MR which is used to stage and diagnose things. But the one that we may commonly see is osteoid osteoma, which may appear as a very discrete area of increased focal uptake on a bone scintigraphy, particularly common around the pelvis. One of you needs to, sorry, can somebody mute their thing? One of you is not muted, and you're making a noise. And what I'm going to do then is mute you. Sorry, can one of you is not muted, and there's a bit of sound coming through. Thank you. As well as that, the fibrous dysplasia that occurs primarily between the ages of 15 and 25. Now, where bone scintigraphy tends to be used is in osteosarcoma and looking for metastases, which tend to be bone seeking. And there are two peaks. The first one is between ages 5 and 15, and the second peak is over 60. And as we'll see, there may be a role for FDG PET as well. Now, unlike most benign disease, there may be a role for three-phase bone scans, particularly looking for focal or local disease. So this is a patient with fibrous dysplasia. You can just see here that on this side of the pelvis, there's slightly increased uptake around the SI joint and the upper part of the pelvis. It's not particularly active fibrous dysplasia. It's not like some of the other diseases where you see, particularly osteosarcoma, very intense uptake, but you can see it. This patient has also had a rib taken out, and there is some focal uptake related to surgery. So the rib that was removed was the primary site, and then there is the secondary site in the pelvis. But fibrous dysplasia can produce quite subtle changes on the bone scintigraphy. Osteosarcoma, however, is completely different in the fact that it is very...
That's not a good image of fibrous dysplasia.
Yeah, I know. Sorry about that. But this one's a good image. You can have a look at it better when you look at it again. Yeah, I do agree. But as I was saying, the problem with a lot of fibrous dysplasia, I was giving you a realistic image. It's not often very subtle. But here with osteosarcoma, we can see much more significant disease load. And where you do have disease, it tends to be much more intense. Now, it is possible sometimes to see soft tissue metastases. They are rarer, and they often aren't positive on the bone scintigraphy. So just because you can't see them doesn't mean to say they're not there. But here we have a patient who has quite widespread bone metastasis from an osteosarcoma. So what about FDG in bone primaries? The paper about 10 years old now from Germany, looking at 70 patients with primary bone tumors. And the majority of those had Ewing's. They had just under half had osteosarcoma. And here you have an advantage because unlike the bone scintigraphy, the FDG can be very positive in patients with Ewing sarcoma. And you can see that when they were looking for both the bone and soft tissue disease, that FDG PET found 95% of all known lesions, but bone scintigraphy only 71%. And as I showed you with that Ewing sarcoma, where the changes are quite subtle, FDG PET is much better. So generally now, we recommend doing an FDG PET study in a patient with Ewing's and not a bone scintigraphy. Now, they did note that in a couple of patients, they saw some sites of disease with a bone scintigraphy that they didn't see with FDG PET. I have to say that's not been my experience, but that's what they reported. So this is an illustration from a more recent paper, sorry, an older paper, but a slightly better paper. And this is from Peter McCallum Centre in Melbourne in Australia by George Toner and Rod Hicks. And what they were doing is they were looking at what you could see in terms of response to treatment. So the baseline image is an FDG PET study of a youngish gentleman. He's in late teens, and you can see you do get FDG uptake in epiphyseal plates, low-grade uptake, but it is definitely there. But you can see that the osteosarcoma has intense uptake of FDG. The patient then received chemotherapy, and you can see in the post-chemotherapy images the characteristic bone marrow activation of patients who have become anemic due to chemotherapy. But what you can also see, if you look down into the femur, is there's been a very good response in terms of FDG uptake. And this patient then went on to have that femur replaced by a prosthetic femur, which is the surgical treatment. So FDG PET seems to be good, not just for diagnosis, but for monitoring treatment. So I think now in the world of PET, we would recommend for these bone sarcomas that we would consider FDG PET above bone scintigraphy. So more commonly, we're doing bone scintigraphy for metastatic bone disease. And if you remember Dr. Buscombe's 5 Bs, which are the 5 cancers most commonly causing bone metastases, and that's breast, bronchus, prostate, kidney, and thyroid. And remember, again, the test is sensitive but not specific. So why do certain cancers favor bone metastasis? And the reason for this is unclear, but it may be related to blood supply and oxygen levels. So we know that the kidney tends to go to lung and bones, whilst breast prefers bones and brain. So it's a little unclear why certain metastases grow in certain areas, but it's probably to do with the sort of microenvironment they can create around them. So when we know that from the very first day of diagnosis, there's about 1 billion cancer cells in a patient's body, and many of these are circulating. So there's potential for metastasis at any point. And what seems to happen is at certain points, these produce clumps of cancer cells and then become a new metastasis. Now, the areas of the skeleton in a normal patient that they tend to go to will be those which is red marrow distribution. So in a patient who doesn't have, for example, thalassemia or sickle tray, this will be the skull, the spine, the ribs, the sternum, the pelvis, proximal humeri, and femora. And the general rule is the proximal 40% of those long bones. Now, if you have a hemoglobinopathy, such as sickle, or even sickle tray, or one of the thalassemias, which, as you know, is more common in an African population and a Caucasian population, you can have extension of red marrow peripherally, and that will change the pattern of where you see bone metastasis. Now, we do call these bone metastasis, but in fact, they are actually bone marrow metastasis. I'm just trying to get, somebody's put something in the chat, which I'm just trying to get down, but it doesn't work when I'm in screen sharing. I'll deal with it in a second. Come on, where's my chat room? I can't do it there. It'll come up in a second. I'll look at it in a second. So whilst we call them bone metastases, they're not true bone metastases. They are in fact bone marrow metastases because they start in the red marrow. And at that point, when they're bone marrow metastases, it may be possible to see them in the MR or the FDG PET scan or PSMA PET scan if you're doing prostate. So we've got a message that some people in Durban have trouble joining. My suspicion is that's a Durban issue because the rest of you managed to join, but hopefully they'll be with us soon. Okay. So what then happens is that these metastases grow. When they impinge on the bone tries to remodel, and it remodels by two actions. The osteoclasts break down damaged bone, and that gives you a lytic lesion, which we can't really see. But osteoblasts and fibroblasts try to reform bone around the metastasis, and that's where we see uptake of MDP. And that's where we see the increased uptake of NDP that's classically seen in bone metastasis. So here we have a patient who's a 55-year-old female with breast cancer diagnosed 5 years ago. And this is a very typical pattern, unfortunately, where we see multiple bone metastases. But those of you with sharp-eyed, if you look at the skull, can you see there's a ring? And in the middle of that, there's a hole. And this is where there's a much more lytic process going ahead. And this suggests a much more aggressive tumor. And that would need to be further investigated because that patient may need to have radiotherapy, partly because obviously underneath the skull is the meninges and the brain, and we wouldn't want to have direct invasion. So if you ever see an area with reduced uptake, then make sure that you do report that as a particular area of concern. Too often we see scans like this, and this is a scan of a patient who has some uptake around the jaw. They got uptake in the spine, in the neck, and they got some little spots of uptake elsewhere. And this is the same patient's chest X-ray showing a large bronchial carcinoma. So the assumption would be is that this patient is suffering from bone metastases. But the problem is, as I said, it's a non-specific tracer. So if we look at this, the mandibular uptake could be bad teeth. The uptake here in the sternoclavicular joint could just be some arthritis. And the disease in the spine could be due to degenerative change. And there's some uptake here that could be related to an L5-S1 facet joint. So the problem is even though we know the patient may have a large T4 primary bronchial tumor, we can't assume that these changes are on a bone scintigraphy are due to bone metastasis. Though if the patient was having an FDG PET study for staging their primary lung cancer, then hopefully that would be helpful. This is a much clearer situation. We've got a 55-year-old man here with prostate cancer with a PSA of 123. And by the time you have a PSA that high, it's normal to have multiple bone metastases. Now, those of you who are used to doing PSMA imaging know, of course, that the problem is that a bone scintigraphy doesn't see the soft tissue metastasis. And some of these may not even be visible on CT or MR because of the size of the nodes, for example, maybe under a centimeter and won't be called. So the question is, will PSMA imaging replace bone scintigraphy? And my suspicion is the answer will be to do with cost and availability. So you guys in South Africa and many centers are very fortunate to have a fairly easy access to reasonable price PSMA. In a country like the UK, a bone scintigraphy costs around about $70 US and is available at pretty much every nuclear medicine department in the country. PSMA scanning will cost around about $3,500 and is only available to about 10 hospitals in the UK. So as you can see, at least for the moment, the majority of patients are still being imaged with bone scintigraphy on the understanding that we may not be as sensitive as they are with PSMA PET. Sometimes we see a super scan. So we did see a super scan before when we were talking about metabolic bone disease. But this is a super scan in a patient who has got multiple bone metastasis. It can occur in breast, and I have seen it in thyroid and bronchus, but that's 1 or 2 patients in 30 years. Most commonly, it occurs in prostate cancer. And what you can see is this diffuse uptake in the spine, the ribs, the pelvis. And you can even see the red marrow distribution here in the humerus because the uptake disappears. You can't see the distal humerus. There must be some concern about this focal uptake in the surgical neck because that could be an incipient fracture. So that would need to be x-rayed. But when I showed you the metabolic bone disease of the super scan, do you remember that the distal bones down here in the tibia and fibula were hotter than the bones in the spine? So in a metastatic super scan, the central bones are more active and you can often hardly see the peripheral bones. Though in both scans, you don't see kidney or bladder. So that is really the clue. Hopefully that's the Durban people joining. I should have reminded everybody that they need to use the different Zoom address for the midday ones, but the fact you've joined us means that you realize that. So this is another typical pattern with breast cancer. So I don't know if any of you like going to fancy Italian type restaurants. There's that one in Pretoria we went to a couple of years back where we had pizzas. But if you sit down for a meal, what they do is well, after you've had your pasta or whatever, they bring along this very, very posh pepper grinder, very big wooden pepper grinder, and they grind the black pepper and it sort of scatters all over your food. And that's got a pepper pot distribution. So here we see the same thing in breast cancer with this sort of random spots of the metastasis, and that's called a pepper pot distribution. It's very classically seen in breast cancer. So this is a patient who also has breast cancer with a different kind of distribution. Here the number of metastases is quite low, but you can see very worryingly in both proximal femora, there is focal uptake, and on one side, on the left side, it involves almost the whole width of the femur, and on the right side, there's a dot just in the neck of the femur. So both of those probably earn a check X-ray if it's not been done recently, or check CT to make sure that there's no fracture risk. If you've got a SPECT CT, of course, you can do that all yourself. And certainly if you were running like a one-stop shop, that's maybe what you would like to do, is do a SPECT CT at that site and then determine if there's a fracture risk from the SPECT CT. So all these options are available to us. But this patient, somewhere in the report, you'd have to note the need for further investigation. I think the Durban people are joining us now. So welcome, Durban. You may sometimes see this distribution of activity in a patient where you're looking for bone metastasis. And here we have a rather unusual appearance in the fact that we see the kidneys almost like a DMSA scan. So you may think, oh, there's been some contamination of the MDP with DMSA. Maybe the radiopharmacist contaminated one vial of MDP with some DMSA. But that's actually unlikely. This is a pattern that we see in many patients who have received in the last year or two cytotoxic chemotherapy. And for reasons we've never fully understood, you can get this renal distribution. Now, it doesn't really affect the reading of the bone scan, especially as you can see the rest of the bone scintigraphy doesn't show bone mets, but it's not an unknown phenomena. So here we have another pattern we sometimes see. So this patient has known carcinoma of the prostate with spinal metastasis. And we can see here that there's reduced uptake across the lumbar spine. And if you notice, it's got a very square type shape, or rectangular shape, should I say. Nature doesn't really do rectangles, so that would be a human thing. And we can see this in patients who've had radiotherapy. So this patient, unfortunately, if you can see, there's rather patchy uptake, both in the spine and the ribs and the pelvis. They've got quite extensive bone metastasis, and they have had radiotherapy to their spine. So normally within 6 months of radiotherapy, you may see some photopenic areas in the spine. So here we have a younger patient, 34-year-old, who has a 5-centimeter invasive ductal carcinoma. That's a large primary. And when you look at this bone scan initially, you might think, it doesn't look too bad. There's a bit of a scoliosis. But I can't really see any areas of increased uptake. There doesn't seem to be any hotspots. And I would agree with you, really. But if this works, if you look very carefully, somebody's got a radio on. If that's just turn it off. Can you just make sure your microphone's muted? Thank you. You can see that there is a defect in that sacroiliac joint, and that's a lytic metastasis. So lytic metastasis is a lot more difficult to see than positive ones. If you look at this one, now I'm taking the arrow away, you can see it very clearly, but you may not have been able to see it so clearly without an arrow. Unfortunately, when you're reading the bone scintigraphy, they don't normally put the arrows in for you, so you have to do that yourself. So one of the things you've got to look for, a bit like when you're told to look at a chest x-ray, you're asked to look for the missing rib. The same thing is that when you're looking for a bone scintigraphy, look for the area that's missing, and that may well be the site of a lytic bone metastasis. In some patients, like with renal cell carcinoma, it's not uncommon to have some sclerotic and some lytic bone metastasis. So that's MDP. What about FDG? Well, we know that cancers have an increased glycolytic drive and an increased need for glucose. And FDG is taken up and phosphorylated by hexokinase, and it basically remains within the cells. So though again is not specific for cancer, FDG with PET may offer a slightly better resolution over bone scintigraphy, and we have the advantage of both a tomographic image and a CT. Now the question is, what can we see? Well, the problem is that there's all to do with resolution signal. So in FDG, you'll see the tumor with very high resolution, but a bone scintigraphy doesn't see the tumor, but it sees the bone reaction around the tumor, and that might be a bigger area. So it may be possible still to see some areas on the bone scintigraphy you can't see on the FDG, because you're getting a bigger signal from the reactive bone around the actual tumor. So this is FDG PET in a non-small cell lung cancer, and you can see there's a focal uptake which looks like it's in the rib. And when you look at the CT component, if you look very carefully, this rib is much shorter than its colleague rib, and the other ribs are the same length, so it's not an oblique slice. And this is because there's a lytic lesion at one end of that rib, which corresponds very nicely to the uptake of FDG. So that's a fairly simple one to be able to report. This is a patient, again, with a hilar mass and lytic bone metastasis. But in the pelvis, you can see here that while there's focal uptake of FDG in the pelvis, the actual CT scan is normal. And this is probably because this represents a bone marrow metastasis and hasn't yet caused significant bone destruction, showing that FDG PET may well be more sensitive and specific in these lytic bone metastases. And lytic bone metastases tend to go with the more aggressive tumors, and they tend to be ones that are more FDG avid. And certainly with things like lymphoma, you may clearly see quite a lot of bone disease on the FDG with very little change on the CT scan. Again, this is a pulmonary nodule, and here you have a sort of hybrid image, hybrid tumor. So here we have a soft tissue mass with local bone involvement, and the bone scintigraphy shows a little bit of sclerosis, but it's not marked. This is the soft tissue mass, and here you can see the FDG shows that both sites are due to active disease. And on the MIP image, it's this lesion here. So you can see these sort of joint soft tissue and bone lesions with FDG PET. This again is another patient where we can see a mixture. So here we have uptake in the sacrum, and you can see there's sort of sclerosis on part of this area here in the sacrum. But when we look in the femur, we can see that the uptake isn't actually in the bone, it's in the structure in the middle here, which is the marrow. And in fact, the metastasis has got a higher density than the fat in the surrounding marrow, which is why you can see it against the dark grey of the fat, which has a low density. Now, I suspect if we did a bone scintigraphy, this would be positive, and this may well be negative. So there are some advantages in using FDG PET in bone metastasis. We're able to stage the whole patient, both soft tissue and bone. And obviously, if we were staging the patient for surgery, that is useful. You will almost certainly find unexpected sites of tumor. And the other thing is that, to be honest, if you use the MIP image, you can see the whole patient in one picture. And it's not really affected by partial volume that affects CT and MR as much. So here we have a patient who, interestingly, had an MR of their pelvis because they had pain, and the MR was completely negative. But this FDG PET study, you can clearly see, has a big right lower lobe lung primary. There's some further disease up in the mediastinum. Now, they knew all that, but this bone metastasis was completely negative, as I said, on MR, but is positive on FDG. So there are places where FDG beats MR. Now, our MR radiologists might not like us to tell them that, but it is true that in some patients we can beat MR. So there was a meta-analysis done, published about 12 years ago, looking at bone scintigraphy versus FDG in patients with breast cancer. They didn't have a lot of studies, only about 184 studies, and this probably is worth doing again at some point. And they published this in the Clinical Nuclear Medicine 2008. And overall, they were showing, this was just comparing the different kind of techniques that were used. Some of the bone scans involved SPECT, some of them was just planar. But overall, when they looked at the comparison of sensitivity either by patient base or by lesion base, it was clear that both, in both cases, the FDG PET was better in terms of whether or not the patient had disease. Now, at this time, they said that the bone scan was better for finding small bone metastasis. And we understand the reason for that. That's all to do with this, the fact we can see the bone around the metastasis. But the specificity was much better with FDG PET because we had the CT component. So it may well be that in some patients you'd want to do both bone scintigraphy and FDG PET, particularly if they're symptomatic. But we would normally recommend now that if you were trying to get a total staging of patients, certainly with breast cancer, we would do FDG PET primarily. This, for example, is a patient who had a normal bone scan and has a positive FDG PET. And those of you who are sharp-eyed will note the reason is that in the pelvis there's a pure lytic lesion. So this is unlikely to create a significant response that causes a sclerotic response, which we see on a bone scan. Another report from a similar time, this is from Korea, looking in upper GI cancers, a much bigger group of patients with both esophageal and stomach cancer, all of whom had FDG PET and bone scintigraphy. And they compared the findings with that to operation. And they found that the sensitivity and negative predictive value of both methods was about 95%. But PET-CT obviously could find soft tissue disease. So again, they recommended FDG PET as the primary lesion. The carcinoma of the prostate is a little different, of course, because FDG PET is not our primary method for looking for metastasis in prostate. And they looked at a smaller group of patients. And they found that obviously with PET, they were only getting sensitivity of 65% using FDG. Now, that would be completely different with the prostate-specific agents such as PSMA. You can get non-specific uptake of FDG. It's not specific to cancer. Anywhere where there's an increased sort of metabolic response in any kind of healing situation or inflammation, you can get false positives. The CT can often be helpful to help you to look at that. If, for example, you're doing an FDG PET study and there's an obvious fracture, particularly in the ribs, with low-grade FDG uptake, you're normally pretty happy this is due to a fracture. So the kind of things that cause positive uptake on FDG in bone would be osteomyelitis, Paget's, arthritis, brown tumors, some hyperparathyroidism, recent trauma, osteoid osteomas. And in bone marrow, which may be misread for bone disease if you don't get quite 100% good registration, you can get uptake in anemia, hemoglobinopathy such as sickle and thalassemia, patients who've received EPO for anemia, or those who've had things like GCSF for anemia, particularly they got other problems such as having been treated for lymphoma or leukemia with chemotherapy and had some bone marrow failure. And bone marrow islands and extension, again, some of these should be helped by looking at the CT. So this is a patient who has a carcinoma of the lung. And you can see very nice the FDG uptake in the primary carcinoma. Now, an issue that we may have here in the UK, but we don't have, I'm sure you don't have so much in South Africa, is the issue of brown fat occurring in patients who get quite cold, particularly between the injection and scan. We're just starting to see that as we go into winter here, but you just have to be careful now. So I didn't catch that. You can see some uptake here, but in the CT, it doesn't align to anything. There's no muscle there. There's just areas of low density. So that is fat. So this is probably brown fat uptake. You may see this in some of your patients. Yes, as it says here, just to say the positron range can play a role here, but not major. Yeah, that's true, Mohammed. It can do. And it can be particularly if you have very energetic positrons. F18 sits in the middle, but if you're doing things like ID124, it can be helpful as well. And that can obviously give you a better signal in terms of resolution, but it will mean that you may see smaller lesions, but it may well be that your localization will be reduced. So that is true. Positron carriage will have something to do with it, right? Thank you, Mohammed. This is a patient who has had GCSF for anemia in Hodgkin's disease, and we've done a FDG study, and you can see there's very intense bone marrow activity. This is a fairly young adult, and they can respond very aggressively to growth colony stimulating factors, and they can have very intense metabolic uptake. So every spot of bone marrow will become very active and take up the FDG. You can see these issues quite significantly. Now, the question is, would you see soft tissue disease? We would hope so, but you do have to be a bit careful when it's like this, because you may get a steal effect in the fact the FDG is taken up so much by the stimulated bone marrow that you may not see low-grade lymphoma uptake. And we would normally recommend that we would repeat this study in 6 weeks and make sure the patient doesn't have any more GCSF. This is a patient where, again, the non-specificity can be an issue. This patient has got a colon cancer. Colon cancer does occasionally cause bone metastasis. And we had here uptake that appeared to be in the bone. And when you looked at the bone, there definitely was uptake in and around that greater trochanter. But when we followed this patient up, we found out this was actually due to osteomyelitis, because they'd had an abscess that had sort of blown sideways from their where their tumor was, because the tumor had perforated the bowel and the abscess was starting to go down the thigh, and that was causing the problem. Our good old friend facet joint arthrosis can cause a problem, but again, here's where the CT is very helpful. So here is an FDG study, and we can see quite intense uptake, but when we look at the CT scan, we can see that that facet joint is pretty ragged, so is the other one. That's where there's uptake, and this is spinal cord uptake, and there's no evidence for bone metastasis. So reading the CT along with the FDG should be helpful in working out what's going on. Just to finish off a little bit on F18 bone scans. F18 bones were used for rectilinear scanners in the late 50s to 70s. But if you don't have a PET scanner, the resolution was very poor. But they did know uptake into metabolically active bones. Obviously now with a PET scan, you can now do FDG with just sodium fluoride, not FDG, PET scan with just sodium fluoride. So I thought I'd just show you what an F18 bone scan looked like on a gamma camera. This is with an ultra high energy collimator, one of the early Anger cameras. This image was taken around about 1963. And you can see sort of a skeleton, but there's a lot of scatter from the high energy photons. This is much more recently. This is from Penn State University, from Albert Alavi's lab, and he's done a whole pile of studies looking at different agents. And this is a same patient being studied with MDP, and then there's the MIP image with the F18 sodium fluoride. And what you can clearly see is, first of all, your target to background ratio is much, much better with the sodium fluoride. And if you look at the spine, particularly, you can much more clearly see the multiple bone metastasis. So you will see more bone metastasis on sodium fluoride, but the question is, how clinically useful is that? And that's always been difficult to prove. There was a paper in 2007 looking at patients with prostate cancer, imaged with both MDP and fluorine-18. 23 of these patients were found to have metastatic disease. When they looked at planar bone scans, it was a 70% sensitivity. SPECT put it up to 92%. The sodium fluoride found all the lesions. And specificity was improved with the sodium fluoride PET, but that's again not due to the sodium fluoride, but due to the fact that you had a CT scan you could read with it. And this was one of the images from their paper. So here you have a bone scintigraphy in panel A, and you can see that there is an osteophyte here. And but when you do the sodium fluoride, there's uptake in the osteophyte. So that is not a bone metastasis. Here, however, in this vertebra in the thoracic spine, there is nothing on the bone scan or even the SPECT study, but there is focal uptake on the sodium fluoride. So showing here the sodium fluoride is more sensitive than even the SPECT bone scan. This is part of a study that we were involved with looking at sodium fluoride versus MDP in patients with renal cell carcinoma. And this is a number of patients that we had. And here we found that there were, we looked at 10 patients with metastatic RCC with 77% lesions identified. With sodium fluoride, we found all the malignant lesions. CT found 46% of those, and MDP found just 29%. And one of these are just a few examples. This is a bone scan, which shows rather mottled uptake with uptake in one site. But you can see here, this is a mixed lytic and sclerotic lesion. And the sodium fluoride really shows you much better the extent of disease. This patient had a negative bone scan due to a lytic metastasis in the posterior arch of the vertebra, which is positive on sodium fluoride. And here we have a bone scan that's negative. Here we have the CT, and here we have a sodium fluoride. And very interesting, we see two lesions, two vertebrae with no uptake of sodium fluoride. And these vertebrae on MR were just stuffed full of tumor. So there was no bone, but you can't see that on the bone scan, probably a resolution issue. And this is one which, again, the CT is basically negative, but there's a small area of uptake on the sodium fluoride. So the sodium fluoride was the best agent to use in these patients. But a warning that sodium fluoride is not specific. In fact, in many ways, it's even worse than MDP because of its increased sensitivity. You can pick up a lot more false positives. I've shown you some facet joint arthrosis before. Here it is with sodium fluoride. This is a patient who's got active osteophytes with uptake of sodium fluoride. And here is a Paget's disease of the distal humerus, very nicely seen with sodium fluoride. So you will pick up the same kind of false positives, but obviously with a CT scan, you might be able to identify those a little bit better. So in summary for our first talk, MDP remains the standard test for finding bone metastasis. Metastasis follows the distribution of red bone marrow, but remember that in some conditions, red bone marrow distribution can change. FDG may be particularly useful in finding lytic lesions that we don't find on bone scintigraphy. In some patients with lytic and sclerotic lesions, then sodium fluoride might be more sensitive than MDP, and certainly worth considering if you have that available to you. So thank you very much. I'm going to just stop sharing now, and I'm going to stop the recording. So